Hi everyone, my name is Shiv Shah, and for my Bio 340 honors project, I decided to study Staphylococcus aureus. Specifically, we're going to be looking at the genetic variation in Staph aureus bacteria and how it confers resistance to antibiotics. And the most common situation we see with resistance to antibiotics is MRSA, or methicillin-resistant Staphylococcus aureus. However, before we can even begin to understand the complexity that goes into this mode of resistance, we need to talk about Staph aureus as a bacteria alone. So Staph aureus is a really common bacteria, and actually 30% of healthy people will probably have Staph aureus on their skin. It will be colonizing on their skin, and it's really just a part of part of the natural skin flora. It won't cause any symptoms, and it's very, very ubiquitous. What's really important, however, for our understanding of Staph aureus is the fact that it's gram-positive. So what exactly does that mean, that it's gram-positive? Well, when you do a gram stain of Staph aureus, you're going to find that it's actually it's a dark purple hue. And why is that? Well, there's this thick layer of peptidoglycan on the gram-positive cell wall. And this thick layer of peptidoglycan is really important because as part of the bacterial cell wall, it confers stability and integrity. Now, when we're talking about bacteria replicate. And when we're dealing with an infection, sometimes the bacteria replicate extremely quickly. And so one way to deal with an infection is to stop bacterial replication. So that's really where the cell wall comes into play. If you can't synthesize a cell wall, you very well can't synthesize or create a new bacteria. Bacterial replication stops if cell wall synthesis stops. So if we're trying to come up with a treatment to stop the synthesis of bacteria, let's start with stopping cell wall synthesis. So if we kind of take a microscopic view into bacterial cell wall, specifically gram-positive bacteria, you'll see that there's this region that's outlined in red. And that is a linkage between different layers of the peptidoglycan. And this linkage is facilitated by this really important protein I'm going to be referring to throughout this presentation called PBP, or penicillin binding protein. So penicillin binding protein is responsible for linking multiple layers of peptidoglycan together. It's a cross linkage with using different amino acids that allows for the cell wall to be synthesized. Now, I mentioned that Staph aureus is usually a normal part of the skin flora. However, there are situations where it can cause some mild infections. So you'll see that with some mild skin lesions, pimples or carbuncles, but it's also been known to cause some more severe cases in patients, including pneumonia, sepsis, and in the most lethal situation, death. So we really need to understand, how can we stop these bacteria from replicating in a sick patient? Well, I mentioned that cell wall synthesis is the perfect way to go about it. And so in the 1920s, Alexander Fleming really completely changed the direction of both medicine and pharmacy by creating the first antibiotic, penicillin. Now, penicillin is a beta-lactam, and this is the main part of a beta-lactam. This is kind of the hallmark characteristic of a beta-lactam, that it has this 3-carbon ring attached to this ketone. And this is particularly important because this antibiotic doesn't just go in the bacteria and automatically kill the bacteria. That's kind of what people usually think an antibiotic is. Well, no, with gram-positive bacteria, it's actually able to stop the synthesis of the peptidoglycan cell wall. And this structure, especially this little ring, is really important for doing that. And so when patients in the 1940s presented with Staph aureus infections, the clinicians would, when patients presented with Staph aureus infections, the clinicians would typically give penicillin. And what penicillin does is that it binds to penicillin binding protein. Oh, wow, I wonder where it got its name from. It's not much of a surprise there, but the penicillin binding protein, which creates the linkage in the peptidoglycan, is inhibited by penicillin. So the penicillin binding protein all of a sudden has this penicillin bound to it. It inactivates it, so it can no longer create more cell walls, and the bacteria are no longer replicating. And that's great because this stops Staph aureus replication. This was the gold standard in the 1940s for Staph aureus infection. Get the patient started on penicillin, and they're going to be doing great. And in fact, they actually found that over 9% of Staph aureus isolates were susceptible to penicillin treatment. So this is great. This is the gold standard. We found it. However, like all beautiful things, they eventually will fade. And in the case of penicillin, what happened was that it was rendered, in many cases, completely ineffective against Staph aureus infection. So the bacteria are all of a sudden resisting treatment, and everyone's scratching their heads thinking, oh, what's going on? Well, what happened is that resistance arose. And this is the case for many antibiotics. Whenever any antibiotic really comes along, resistance will arise rather quickly. Certain bacterial cells will naturally fend off the antibiotic influence. And in the case of Staph aureus, there are two mechanisms which we will be discussing in this honors project. The first is when all of a sudden these bacteria start producing an enzyme called penicillinase. And what penicillinase does is that it hydrolytically breaks this really important bond between the carbon and nitrogen in the beta-lactam. So remember how I referred to this beta-lactam, specifically this part, this red part, which is really important. Well, it's because if you break this bond right here, you essentially render the entire antibiotic ineffective. How come? Well, remember, this antibiotic binds to penicillin binding protein. So if we have a broken antibiotic, it can't bind to penicillin binding protein, and penicillin binding protein will continue to build cell walls. It will continue to allow for the replication of bacteria, and the patient is not getting any better. And we've seen this multiple times over many years. There's multiple waves of antibiotic resistance in Staph aureus. So 1940s, penicillin was introduced, resistance. Methicillin was introduced, resistance. Different dosages of methicillin were used, resistance. Eventually, vancomycin, which was a last case antibiotic, was used to treat Staph aureus infections, resistant. So we see this pattern emerging, and that really emerges through these waves of resistance. Well, what's causing this resistance? And for a long time, scientists were puzzled by this question of what's causing resistance. And in Staph aureus, Dr. Chambers describes it really the best. And he says that antibiotics constitute the most concentrated selective pressure on Staph aureus isolates in its long coevolutionary history with mankind. I couldn't have put it better myself. And really, that's kind of the driving force for the increased rates of different variants of Staph aureus. When clinicians continue to throw the kitchen sink in the treatment of Staph aureus, they continue to use antibiotic after antibiotic after antibiotic. Eventually, the bacteria are going to evolve and gain resistance to bacteria. Remember, bacteria are driven to evolve resistance to anything that really affects its ability to thrive in its environment. So what really causes this resistance? Well, the kind of the undercurrent for this resistance is in genetics. So we see a vast number of genetic variants of Staph aureus infections, and much of that is due to one gene. There are multiple genes involved, but this is really the hallmark gene for Staph aureus variants, and that is the MECA gene. So the MECA gene actually codes for the penicillin binding protein. So if we have a variant MECA gene, there's two things that can happen. It can create penicillinase, which renders penicillin ineffective, or it can actually modify the penicillin binding protein. So if the penicillin binding protein is a little bit modified, it can continue to create the cell walls, but now beta-lactams can't bind to it. So we have there two mechanisms of resistance by the MECA gene. Now, it would be easy to be able to target this gene, and all of a sudden, we'd be able to cure our patients. But remember, bacteria are consistently driven to evolve, as Dr. Chambers mentioned, and the selective pressure that antibiotics places is increased resistance to medications. And so in the case of Staphylococcus aureus, the introduction of methicillin greatly impacted Staph aureus treatment because it initially helped patients for a long time. But after about even just 3 months, cases were found where there was actually a lot of resistance to the genes. And part of this resistance is due to the fact that there are 5 distinct clonal complexes of MRSA. So there are 5 completely different genes that code for the penicillin binding protein and the penicillinase, and that makes it really hard for clinicians to treat. But how exactly does that happen? Did it just come out of nowhere, the penicillinase and the modified PBP protein? Well, no. Remember, the underlying current of variation is in genetics. And specifically, when we're dealing with bacteria, we see a unique process known as conjugation occur. So a plasmid is just a small circular strand of DNA that contains certain genetic elements. And in many cases, the MECA gene is actually found in the plasmid. Now, what's so awesome about the plasmid? Bacteria can actually transfer plasmids directly to another bacteria by a process known as conjugation. That's what we see here. If another bacteria is in close proximity to one bacteria, it can transfer this plasmid. Now, if the plasmid has a gene that is codes for resistance to antibiotics, that's bad news, because as the bacteria continues to grow, the genes that it can pass involves resistant genes to antibiotics. That's not good for the patient, because the bacteria are going to continue to reproduce and the infections can continue to grow. And so this image really shows that the culprit of resistance is this plasmid with a certain gene on it. And so as this gene is transferred horizontally to other clones, eventually it brings about variation. And in the case of MRSA, we see 5 different clonal complexes that bring rise to almost 6 to 7 different allotypes of the MEC gene. That's a lot of variation, and that primarily comes through this horizontal gene transfer. Part of this gene transfer involves a small degree of mutation. And as that happens thousands and thousands of times, you get this really heterogeneous group of bacteria that become really hard to treat. So let's go back to this idea of MRSA being really hard to treat. Well, what really makes it hard to treat? Well, this is a big problem in the healthcare setting, because a lot of times when you have post-operatively chest tubes and catheters, well, Staph aureus actually secretes this biofilm, and it will actually latch on the Staph aureus. You can see, well, these red dots will actually latch on to the catheters and create this perfect breeding ground for conjugation and horizontal gene transfer. So if a single bacteria has a mutated MEC gene that codes for resistance to antibiotics, it can all of a sudden pass that gene via conjugation to all these different bacteria, and that causes a real problem, because now in a medical setting with a patient that might have just undergone surgery and is immunocompromised, you see this resistant bacteria start to develop and replicate, and that causes a lot of issues in the patients. I mentioned earlier today that it causes pneumonia, it can cause sepsis, and in fatal situations, death. So how does genetic variation impact the outcomes on the host? Well, first of all, the increased variations that's brought upon by the use of antibiotics really causes all of these different waves of resistance. So when penicillin was first introduced, the Staph aureus eventually developed resistance to that. When methicillin was introduced, Staph aureus developed resistance to that. When vancomycin was used in 2002, scientists actually found resistant strains to vancomycin, which was a last case antibiotic, which is not good at all. And what causes these degrees of resistance is all these different types of genes, particularly in the MECA gene. So as bacteria continue to pass along this genetic information with one another and share it and conjugate it, they actually unwittingly are able to produce different mutants or different types or variants of the gene. And that's bad news, because the more and more variation you get, the more phenotypically dispersed the bacteria are, the harder it is to treat. So from a public health standpoint, there's a lot of work that needs to be done in understanding the mechanisms behind resistance. While horizontal gene transfer is one postulated theory, there are many other theories behind resistance to antibiotics. And in the case of MRSA, which is the resistance to methicillin, we see all these types of strains, such as USA 100 and USA 600, which is really common in the hospital setting. Clinicians have a hard time treating these diseases. So the best way to avoid them is to avoid having Staph aureus in the first place. So practicing good hygiene, hand washing is especially important, not only preoperatively, but also in the postoperative care for patients. And here are my citations that I used for this presentation.